Hello, everyone, and welcome back to another micro lesson. We're continuing this series with the endocrine system, and we're going to go over and discuss the hypothalamus, the adrenal glands, and the pituitary gland. Oh my. And what I want to discuss today, these components are so important to unlocking key exam questions just by understanding the patho. And so that's kind of how we're going to go through this today. So let's get into this. The hypothalamus is an intricate communication hub, okay? It utilizes neural pathways and hormones to integrate the endocrine and the autonomic nervous system. It has several gland secreting hormones, but our focus for today is going to be the adrenocorticotropic hormone, or the ACTH hormone. Now, also, the posterior pituitary gland connects via neural pathways that causes secretion, the release of ADH. And as you recall, we were talking a lot about ADH in our last micro session. So if you hadn't viewed that, now's the time to view that as well. Now, one of the things that the hypothalamus works all these things out is based on a negative feedback loop. Basically, you have a target gland, it is excreting a hormone into the body system. The other mechanism that connects with that gland, it senses that hormone is in the body system, so it'll either inhibit the mechanism from producing that secreting hormone or reabsorb. So that's kind of what the negative feedback loop is all about. And so I would really look into that, kind of know what that is about. That will probably help you on some exam questions. Now let's talk about the adrenal glands. What do they do? Because this is a big one that's going to carry you through the rest of this semester. They're going to produce steroids, amines. They're going to also produce epinephrine and norepinephrine. Do you remember what epinephrine is? Have you heard of that before? Well, you have. Probably if you have done any practicing with CPR, that is one of the first line drugs to bring a person back from the gates, okay? And norepinephrine is a huge drug that supports blood pressure stability. It's also called Levophed, and you most likely see that in your rotation in an intensive care unit. Huge, potent vasoconstrictor. All right. The other components of the adrenal glands is the steroidal hormones. All right, so we've got mineral corticoids, and you've heard of that one too. That is aldosterone. That's going to regulate our sodium and potassium. Also, we have the glucocorticoid, which involves cortisol. I know you've heard of that one as well before. That's going to suppress their immune system. It also impacts the stress response on the body, and it helps develop our sex characteristics. All right. So now that we have all those things in mind, understanding that patho is going to help inform us on what our assessment will look like. So when we get into Addison's and we're talking about, this is adrenal hypofunction and insufficiency, and I wrote this like this strategically because I want you to, when you're writing your notes or your note cards, I want you to put all of it on there. Don't just say Addison's disease, because maybe your national exam will not have Addison's. It'll just say adrenal hypofunction and or adrenal insufficiency. So I want you to get used to your eyes seeing and your mind knowing that this is all a part of Addison's disease. So one of the neat little tricks that I like to use with Addison's is ADD. It means to add. So we understand that this individual needs something added to them. They're low or lacking in some things that could really be detrimental to their life. And one of the things that could happen if they lose too much sugar, their potassium is too high, they can definitely, this leads to Addisonian crisis. And there's always something about a crisis on test taking materials. So you really want to pay attention to what does that assessment look like when someone's having a crisis, and how do I treat said crisis. Now remember, we said all the things, all the components of what the adrenal glands have: steroids, amines, blood pressure control, basically, and stability. So we understand the cost of what could happen if this individual goes into crisis. So one of the things we're talking about, high potassium. How do we identify that this individual would have high potassium? Maybe they're complaining of some muscle aches. Maybe they might be complaining of some dizziness. Hopefully, they're hooked up and being monitored on a tele floor, if not already in an intensive care unit or step down unit area already. So we can see them on the monitors. Maybe if we had a 12 lead, maybe we're going to see some T waves. And I don't know whether you have gotten into that or not, but the T waves will be impacted to identify that maybe there's something wrong with the K. Hopefully, we'll draw some Chem 7, Chem 10, BMP, BMET, wherever you're from, so that we can also establish, okay, this potassium is very high. Now, what are we going to do about it? Well, if you don't know the sodium potassium pump, you should review that. It's actually pretty cool. But we need to shift the potassium that is in the extracellular system right now back into the cell. And how we're going to do that, that is with dextrose and regular insulin. All right, so this is why it's important when you are managing your patients that you're assessing your patient, but you always need to check and make sure they have great IV access, because you don't want to come in and have this crisis and now you don't know what you don't have the tools you need to get this patient back to health again, because now you got to struggle and find a good IV. Now, that doesn't mean that IVs can't go bad during a shift. But one of the best ways to be proactive is to make sure you're flushing them in the beginning, so at least you knew it was good in the beginning. All right. So what could activate someone to having a crisis is another question that I would ask you. And that would be if they're getting an adrenalectomy. And we need to anticipate the IV fluids to maintain equilibrium in their body system so it won't trigger a crisis during surgery as well. So there'll be a whole huge regimen. This individual will probably definitely be in the ICU versus on a med surg floor or a step down, because you don't want them going down, because their electrolytes are depleting fast. So the patient's gonna be like, meet me in the ICU, I'm going down. Meet me in the ICU, I'm going down. Get my sugar levels up, get my potassium down, or I'm really going down. Meet me in the club, I'm going down. Sorry, I had a moment. But now you get the picture, okay? So next we need to talk about Cushing Syndrome. All right, and so Cushing Syndrome is the opposite. Okay, now we're moving into hyperfunction. Okay, we've gone from a state of hypofunction and insufficiency to hyperfunction. So first we need to know, what's our patho? And right with Cushing's, you want to focus on where is the incident. So, what's the primary cause? What's the secondary cause? That's important so that we know how to manage and fix it. Okay. So, as you see here, decreased adrenal glands, that's the primary source. Okay. Secondary would be the overproduction. Okay. And how do we even determine if this individual has Cushing's? We would need to do a DEX suppression test, probably need to check cortisol levels and do a 24-hour urine. Now, if I was probably near the beginning of the program going through endocrine, I would probably anticipate what would be the correct steps in doing a 24-hour urine. If I'm near the end of the program, then I need to anticipate, why would I be getting a 24-hour urine? What does the DEX suppression test look like? How would I educate my patient about this DEX suppression test? What wouldn't I give my patient? What can't my patient have before we do these tests? What is the medication regimen? So that's the level of questioning that you want to do with the Cushing syndrome. Now, the characteristics that a person would present with Cushing's is they could have moon face, a hunchback, striae, and all these characteristics fit very perfectly for some good select all questions. So anytime you're dealing with, Addison's or Cushing's, I would definitely look at what are the characteristics and put them on a note card, test yourself with your classmate, and really make sure you understand the characteristics, because that does open the door for a lot of some good select all questions. Just FYI, just saying. So let's move on to the causes and treatments of Cushing's. So when we're talking about pituitary adenoma, or this is indicating where the incident is, and so how we can treat it, because cause equals treatment. All right. So if we know where the insult happened, that's where we need to target our intervention. Okay. So pituitary adenoma, we know where to target. We need a part or complete adrenalectomy. Do we need a total hypophysectomy? So what I would do is understand what it means for each surgical option and how to educate your patient regarding these surgical treatments. Now, what I will say is the hypophysectomy, that's usually going to be through a transsphenoidal approach. So up through the nose. The patient's going to come back with basically what looks like, for all intents and purposes, a tampon in their nose. All right, you are not going to remove said tampon. You're going to keep it in the nose, and you're going to alert the surgeon, of course, if there's excess bleeding. But your role would be to support that tampon, make sure that they aren't in a place where they were sneezing or there's excess bleeding. Now, whenever you are in these complex topics, one of the things that I want to make sure you remember before we leave today is that you always want to monitor for the opposite of the intended effect. So if we're going through the nose and we are manipulating with the pituitary, there is an off chance that this patient could have adverse effect and start dumping urine. If this is the case, this will turn into a medical emergency. All right. So what does that mean for you? That means if we're monitoring for the opposite of the intended effect, that this person is on strict I's and O's, that you're monitoring output hourly, and you need to monitor and see if this patient is dumping more than 3 liters in a 3-hour period. I mean, that's an exaggeration, but that's call worthy to the surgeon. All right. And no, I don't care what time of night or day That is an emergent call because we need to be thinking about what kind of medication that they need to have. And that also opens the door to another good type of test question. Okay. So now you see how we use the patho to kind of instruct our characteristics. So that's our assessment. We also can anticipate lab work from our patho that we went through by understanding what's going on. And we also can infer management as well. Important that you don't get stressed out and that you know that this is just another learning opportunity for you. Okay? It's nothing to be afraid of. The endocrine system is fun. All right? We're just making sure nobody's going down. We're keeping people from going to the gates, okay? They can't go. Especially if they're not DNRs. We don't want them to go, okay? All right? Even if the DNRs, if they don't want to go yet, we're not letting them go. And this is how you not let them go. You just pay attention to your patho and follow it all the way through. So I'm Dr. Sharonda Sturm, and I hope you had a fantastic micro lesson. And I hope this helped break down the endocrine system in a fun way, but also gave you a little food for thought and hopefully help you understand that no matter what happens, you are enough. Let's see, what am I going to talk about next? You have to stay tuned. I've been grappling with a couple of things, and I think it's going to involve an equation that is very important and that is going to be super important through the rest of your semester.